See the panoramic view, you can see the dental implant which is inside the maxillary sinus, and the sinus looks healthy. Okay, so this is the healthy sinus. So we offered him endoscopic removal, and we operated him 2.5 months later. Okay, so it's a relatively short time, and the patient was asymptomatic. Okay, so I'm showing you now the video. Look at the maxillary sinus. It's all inflamed, a lot of polypoid tissue, there was pus, a lot of granulation tissue, so this turned very quickly into another unhealthy sinus. And really you cannot even see the extruded implant inside the sinus, so we had to dig a lot, and then we found it stuck somewhere here. And I'm showing just to show you how we took it out. This is again an inferior ostomy like Professor Lanzo saw before. I usually inflate the Foley catheter inside the nasopharynx because this can be expelled while you take it out, and I don't want it to fall into the nasopharynx. This is the second case, a 72 years old male referred to by his dentist 4 months after dental implantation, complaining of pain over the left maxillary sinus. So he was symptomatic. You can see the panoramic view, you can see below the orbit, you can see the tip of the extruded implant. Again, the sinus looks normal. However, in the sinus CT scan done just prior to surgery, you can see that the maxillary sinus is completely opacified. You can see the sinus lift. You can see the tip of the screw of the dental implant, which is stuck here. The patient was taken to the OR, and on the table, before we started everything, he had an MI, so we canceled the surgery. And then he was cured, and the implant was later expelled spontaneously into another cavity, so we didn't have to take him to the OR. So like Firas said before, it's better to have imaging right before the procedure because they can be extruded spontaneously. This is a short review of other cases. We did endoscopic removal of within 3 weeks to 8 months with a median of 7 weeks after the imaging studies. During intraoperative inspection, we noticed mucosal changes in half of the cases and migration of the dental foreign body in all cases, so it doesn't stay where you initially saw it. All sinuses eventually healed on endoscopic examination, and the patient became symptoms-free after operation. So in conclusion, migration of these dental foreign bodies and mucosal changes may occur over a relatively short period of time, eventually causing secondary odontogenic maxillary sinusitis. So we therefore favor early removal, so we think the timing is key here. You don't have to rush into the OR, but it's better to operate as soon as possible. So in conclusion of our this round table, odontogenic sinusitis and dental rehabilitation, we see that the maxillary sinus can be very affected by dental issues. Endoscopic sinus surgery is very safe and effective for management of the maxillary sinus pathologies with or without dental origin. We all know that. And collaboration between dentists and rhinologists is essential. Now, just to be on the smiling part, why do we have to deserve to win this competition? No, it's like a competition, so why do we have to fight with the reserve? First of all, seniority, all of us chairmen of the Israeli Ceramic Society, our role, quality of the presentation, I hope that you enjoyed it. Major role of the maxillary sinus that I showed. And I think the most important is promotion of collaboration. This is now becoming more and more accepted that you should collaborate with your colleagues, and I think this is better. Thank you very much for your So we have 3 or 4 minutes for questions or comments. Yes.
Thank you. I'm Pete from Singapore. I want to congratulate the videos of the SEMA method. It's shown very clearly. The one where you do submucosal removal of teeth atrocity. But there's actually another method which I think may be very useful that you should look up. It's called a pre-lacrimal approach. It is where we get much better view of the maxillary sinus. We chisel between the attachment of the inferior terminate and the edge of the premolar capita. When we open this up, we retract the lacrimal duct medially, and we have access to the entire maxilla with a straight instrument, except if there's pneumatization of the maxilla underneath the nasal floor, which is not common. And after which, we put it back, and then it's just as plastic surgery as the SEMA method. This was first described in China from Beijing about 15 years ago, and is widely used now all over the world, the States and the Europe. Thank you.
Okay, there's a place for both procedures, and pre-lacrimal, a different procedure. There is a room for both of them. The point is, doing the SIMA, you're dealing with a very thin medial maxillary wall. It's very easy to penetrate it. You don't need any drills. You don't need any chisels. You don't have any cosmetic problems at the cheek area, as some people mentioned, and problems of less of sensation during this procedure. So it's much lesser potential for complications. And another thing is that when you do the prelacrimal, sometimes you are limited by the nasolacrimal duct itself. So not in this procedure. You can really go around the nasolacrimal duct to see the whole sinus and to work from there. Now for very more aggressive tumors, yeah, the prelacrimal.
Yes, please.
I'm Kordosz Szczygielski from Poland. Thank you for a very interesting session. I have a question about treatment strategy. If you have patient with periapical lesion, and at the same time unilateral sinusitis, maxillary sinusitis, frontal sinusitis, what is your strategy? First, remove the dent, or first to perform press, or do both in the same time. Remove the dent and fess in the same time.
So I can speak for myself because, as you saw, there's no algorithm. But usually what we do is we send them first of all to our dental colleagues, and this is why you need to collaborate with a good dentist that can treat them. Usually the dentist will depend again on the pathology, the specific pathology of the dental issue. They'll try to manage it conservatively, if possible. If it works, then okay, you're done. Because usually when you treat conservatively, when the dental issue becomes clear, then the sinus usually heals if the patient is healthy. So sometimes when there is the odontogenic sinusitis is very long-standing, nothing will help without endoscopic sinus surgery. And in these cases, you'll see that there's no response. Either the patient will remain symptomatic or the imaging will remain pathological. And then you go in and do endoscopic sinus surgery. I don't think there is a good reason to do a collaborative surgery initially unless there is a clear indication for it. For example, if there is, you see there is a dental implant which is, you're sure that it will not stay there, then maybe you can go. If there is an oral fistula that will not close by itself. And from my own experience, for example, even if you have an oral fistula and it's small, and you operate the patient and the sinus heals, there is a good chance that the oral fistula will close. So you really don't need to do a combination procedure, but this is debatable. Okay, you can do whatever you want as long as you treat the patient conservatively initially and then operate them in, because we know that there are complications to surgery on that aspect. If you ask one to comment on it.
Thank you very much.
I understood your question well. If you ask if there is sinusitis due to periapical lesion, that's right. So in many cases, as we are in the team, just to decide what we are doing, in many cases like this, we are sending special for endodontic surgeon or endodontic specialist to do endodontic treatment, and in some cases or in many cases, they will manage to resolve this problem with endodontic treatment. If not, so we will decide to take this tooth out or not, or just doing this combined surgery. So in this case, this special cases, you have to decide with this END team just to discuss whether that's the best treatment doing surgery, conservative, or just only surgery.
Okay, so I think we're out of time. One last question because we started later.
Thank you very much. I'd like to ask you if you use short course steroids or steroids. Let's say in your case, the first case, the early sinusitis after the sinus leak? No, for him, and you can also.
Maybe sometimes in a short course, but not as usual treatment.
Okay. But in the complications, that's why I'm asking you.
Yeah, it depends. If you want to try to conservatively to try, but usually we just maybe local treatment, just decongestant local treatment, but not systemic one, because we are speaking of infection. But it depends. Sometimes it will be very short. This is not our
Thank you very much.
Yeah, I use nasal spray, so you know. Okay, so I'll start. Thank you. I want to thank the panelists, and I want to thank you all, and enjoy the rest of the day.